There you go. Well, wonderful. Well, first of all, it's a pleasure to be here. I wanted to start, actually, if I could have my first slide up, just introducing the case. So first and foremost, I have to introduce the most important person here because I'm just the dumb electrician, right? So I'm going to apologize in advance. I'm going to subject you guys to a little bit of electrophysiology first thing in the morning just to make things spicy. So I'm Rahul Doshi here at HonorHealth, but my colleague next to me, as you all know, obviously a participant in this meeting and a foundational member of this meeting, Dr. Alok Sharma, who comes from us all the way from Minnesota. And then I actually want to introduce the rest of the team. Obviously, critical parts of any cardiovascular procedure, and certainly a structural procedure or an AF ablation, as it turns out. Dr. DeMarco is behind here from our CV anesthesia standpoint. We have our cath lab staff. So Krista's our scrub tech for this particular case. We have Yui, our radiation or our fluoroscopy tech. Christine is our nurse in the lab. And then we have a variety of folks who are supporting the case from industry, because it turns out, as per usual, it takes a village. I definitely want to shout out to somebody that's been a feature of this meeting all the time. Christy, she guides us through all the appendage cases. And then I definitely want to mention the fact that we actually have electrograms, which I'm actually going to force you guys to take a look at for a sec. And so we have support from Abbott Medical from that regard as well. So with that, let's go to my slides again. Here are my disclosures, and as per usual, don't listen to anything I say because I'm horribly conflicted, and Dr. Sharma, of course, speaks the truth. We'll start off related to, and obviously following up on the discussion and the lectures you just heard regarding the left atrial appendage. I'm always fond of saying that if you do the math, this is the most lethal structure in the body, just with the amount of atrial fibrillation in the world and the amount of strokes that are related to atrial fibrillation. And obviously the overwhelming source in non-valvular AF is the left atrial appendage. We can go to the next slide. So as you may or may not be aware, not coming from the EP side of things, in October, CMS finally granted approval to allow us to do concomitant cases. And what I mean by concomitant is doing an AFib ablation at the same time as a left atrial appendage occlusion. And that's really based on a trial that we're going to talk about in a second, or in the second part of this. But we're going to start with the AF ablation and go to the next slide. This is the patient information. He's a delightful 77-year-old gentleman, symptomatic, highly symptomatic actually, paroxysmal atrial fibrillation, drug refractory. Interestingly enough, he was noted to have a soft plaque on his right carotid at the time he had a TIA, but his most recent imaging was actually completely negative. So he has his prior history of TIA. He has a history of obstructive sleep apnea, which, as you know, is a risk factor for atrial fibrillation. He has a dual chamber pacemaker, and he actually is atrially paced most of the time. His most recent antiarrhythmic medication is flecainide, which has fatigue and dizziness. His CHA2DS2-VASc score calculated is 6 if you count the peripheral arterial disease. And so, of course, that gives a very high stroke rate of 10%. He's on apixaban chronically. His heart is otherwise fairly structurally normal. Ejection fraction 60%. His grade 1 diastolic dysfunction. He has moderate LAE. And so let's go to the next slide. So he's here for concomitant AFib ablation and left atrial appendage occlusion. So the first part of this is going to be the AFib ablation. And we're going to do it with pulse field ablation, which I'm sure you guys are all aware and is kind of the in vogue, latest, hottest thing in electrophysiology. And then we're going to do a left atrial appendage occlusion with a sort of plug device. We're going to use a Watchman Flex Pro under TE guidance. And so the next slide. I just wanted to quickly go through the reason why. I will tell you right off the bat, PFA, I am not the absolute PFA homer. This is not to say that this is the best thing since sliced bread, but it definitely has its place now as our newest source of energy. And this is actually the best data for this catheter system, this waveform, and this trial, the ADVENT study, which was basically a randomized clinical trial, 1-to-1, looking at PFA versus thermal ablation, either radiofrequency or a cryoablation. Next slide. So the primary endpoint was a treatment success. Usual definitions: recurrent atrial fibrillation, 30 seconds in duration, freedom from cardioversion, freedom of use of a drug. Secondary endpoint was the same, but actually looking at superiority. And there was a composite safety endpoint as well, looking at adverse events related to the procedure itself, and then some complications that we're all aware of with AF ablation, PV stenosis, atrial esophageal fistula, et cetera, and of course all the acute events. Go to the next slide. This was a study design. You can see you end up, after screening 741 patients, you end up with about 300 patients in each arm. And again, remember the thermal arm is RF or cryo. Next slide. So this is the important part and the reason why all your EP colleagues are so enamored with pulse field ablation. Your left atrial dwell time, your ablation time, typically your procedure times are a little bit less. And so that's, of course, useful. And it definitely facilitates the workflow, especially if we're going to talk about concomitant cases. Because you're typically using a little bit more fluoroscopy, the fluoroscopy time is a bit longer, but the procedure time and the LA dwell time is significantly shorter. Next slide. This just shows, as far as 1 year effectiveness, traditional definitions for AF, right? Not looking at burden, even though there's data on that now. Pulse field ablation, cryoballoon ablation, radiofrequency ablation, all essentially the same. Next slide. And from a primary safety endpoint, basically they were equivalent. And so basically this demonstrated as a first generation pulse field ablation device that PFA is as safe and efficacious as radiofrequency or cryoballoon ablation. Okay, so I'm going to show you basically now the case. We're going to go to what we have. What we've done already is we've put up, and you can see on the fluoroscopy images, you have a patient who has a dual chamber pacemaker, obviously. We've got a 20-pole diagnostic catheter that's looping around the right atrium along the tricuspid valve annulus into the coronary sinus. And we've got a sheath, the Farah drive sheath, which goes with the system, and then the Farah wave catheter over a wire in a superior branch of what's probably a left common vein. And you can see the pentaspline catheter. I'm going to go ahead.
Rahul, just one quick, just for the sake of audience, we have an 18 French Cook sheath, and the Farapulse catheter is 16.8 French, just to have that in perspective.
Sure, absolutely. And we're doing this because of actually we're going to be exchanging to do the appendage occlusion case afterwards. So we've got our catheter in our basket configuration, which is essentially approximating the ostium within the vein or just along the ostium of the vein, and we're going to start delivering energy. So this is what the typical protocol is. We give 2 deliveries of energy in the configuration. We rotate it to get the splines in a slightly different position, and then we give 2 more. And let's go ahead and do that.
Okay, here we go first.
And one more thing, I think the important thing is when we're doing these concomitant cases, the transeptal puncture is also very important because, we did not know the anatomy of the left atrial appendage. So I think Dr. Doshi, what he did was try to do a mid puncture so that we don't struggle with the difficult anatomies when we're doing the concomitant cases.
Almost ready?
I think it's a great point, Alok, though in reality, quite often you end up just going mid. It is a big sheath. Go ahead and go again whenever ready.
Almost ready.
And so it's difficult to go inferior and posterior because of the right inferior pulmonary veins.
Absolutely. Any one-shot technology. By the way, we've delivered our basket configuration impulses while we've been talking. So now if you look at fluoroscopy, I'm going to put the catheter in this sort of flower configuration. And this is designed, of course, to approximate the antrum. And so we can go ahead and deliver again. And it's the same idea that we're going to give 2 pulses in this location. And then we're going to rotate. Whenever ready, you can go again. Now you noticed, go ahead.
Almost ready.
If you're looking at the rhythm, obviously we've got somebody who's atrial paced, and the energy will inhibit the pacemaker just from a noise standpoint, but then it comes back on. Now you can see, go ahead. You can see bradycardia associated with delivery of energy. It's transient, but that's another reason why we have, whenever ready, you can go again. That's another reason why we typically have a diagnostic EP catheter up so that we can pace if the patient has significant bradycardia. Here, see, we've inhibited, but then the pacemaker will kick in. Okay, so believe it or not, we're actually done with the left superior pulmonary vein. So I'm going to go ahead and now put this in its more collapsed configuration. Actually, I just saw a dissociated potential in the left superior pulmonary vein for all the EP geeks out there. We definitely have, obviously then, entrance and exit block. So I'm going to position the catheter. The catheter is now collapsed. It's a pretty floppy catheter, so you can actually, it's pretty easy to manipulate. And I'm just going to go down to sort of an inferior branch, which that certainly would qualify. And again, approximate the ostium, put it in basket configuration, and we can go ahead and deliver.
So Rahul, so this is a steerable catheter, correct?
Yes, the Farad Drive catheter is a tip deflectable sheath. The catheter itself, the ablation catheter, whenever ready, go ahead, is not deflectable. Okay, so that's our 2 in basket. I rotate it around. We can go again.
Okay, almost ready.
And charging up, yep. Okay, so we've given our 4 impulses in basket. And now again, we'll go to flower. And now we're falling into the vein.
How do they know if they're defective?
So Rahul, what's the typical time to do a AFib ablation with the PFA now?
With this technology, it's essentially about 20 minutes. You can go ahead and go on.
And are you doing this with TEE or ICE, or you can do it either way?
We can do it either way. I mean, quite frankly, we use ICE for most of our procedures, and so we would do this with ICE.
Here we go.
Go ahead. And I'm just going to rotate the catheter, and we're going to go ahead and deliver again.
Okay, just charging.
Rahul, I
And
just
so
want to.
just like that, we've actually just completed the left-sided veins. Go ahead, Hertz.
Yeah, I was just going to say, Rahul, this is sort of amazing to look how efficient this is compared to, the old days of AFib ablation that would go on for hours and hours and hours, right? It's pretty
I'll
remarkable.
tell you what, we were talking about that earlier. I mean, there's no doubt that even with traditional radiofrequency contact force and really the advancements in 3-dimensional mapping, I mean, procedures are a lot faster, more effective, more efficacious than they ever have been. But this is just ridiculously fast, right? And so, but again, this is essentially a one-shot approach in terms of going to each vein. And so it's not delivering discrete energy. I think with that, we're going to go ahead and go to the other room. And so we're going to finish up, do the right veins in the meantime, and then get ready for the occlusion once you guys come back. Thank you, guys. So I've obviously passed things off to my colleague, Dr. Sharma. We finished the right-sided veins, and we've exchanged the Farad Drive catheter, the tip deflectable catheter that deployed the Farad Wave catheter, for a dual curve or double curve delivery sheath. This is the angio. It's up on the screen. Actually, the previous one was a little bit better. But by TEE and by, yeah, you can go ahead and show that, Yuri. Go ahead and go back one more. There you go. I think you guys would agree that a 24 would be reasonable. We've got plenty of depth, right, if we head straight north. So we're going to go ahead and deploy, and then we're going to talk about concomitant data in general. So go ahead, Alok.
Yeah, let's show them the TEE measurements. And I think maybe we'll ask you to go over the initial TEE measurements.
While you're about to do the TE measurements, can you tell us, this is something we don't understand as interventional cardiologists, what is the stick for a PFA procedure versus the stick for a Watchman procedure, and are they the same?
Yes, so I think this was one of the things we were discussing earlier, that with PFA, you cannot go posterior and inferior. So the stick has to be mid at the as the best option, and sometimes it's little anterior and mid. But Rahul, I'll pass it to you since you do it.
I mean, so it's obviously it's a bigger sheath, and the idea is to get this, catheter that's designed to sit in the antrum on the right inferior. And so if you're a posterior inferior stick, getting it there is a little bit more difficult. So we typically want to go more anterior. The reality is, in most anatomies, mid just works fine, and obviously works fine for this as well.
Rahul, how are you measuring the size of the left atrial appendage closure device you're going to use? Our EP colleagues tell us that there is some edema after the ablation, and the size may change. And
Absolutely.
And you measure before, you measure after. How do you base your decision of what device size you're going to use?
So it's a great question, and I will tell you it is variable, but there's no doubt that the idea is that when you're ablating, particularly the left-sided veins and particularly the left superior, you're affecting the ridge. And of course, if the ridge gets edematous, you're going to affect potentially the ostium. Now, the reality is it doesn't change as much with cryo or PFA. It does with RF, but even for a usual PVI case with RF, it's usually not an issue. Where it really comes into play is if you're going to do an extensive catheter ablation on a persistent and you do left atrial appendage electrical isolation. In that case, you can decrease the diameter, if you look pre and post, by 0.5 centimeter or more. In fact, it's pretty impressive. Obviously, Dr. Sharma is deploying the device. But it's a great question, and it actually relates to something I think we'll talk about later is the leak rate after this. So,
yeah, I think that's a great question, and that are the things I asked Rahul earlier as well, and that's why I wanted to go over the measurements earlier. Maybe we can go to the pre-procedure TE measurements, and
but that essentially answers the question, right? We did get measurements pre, but I wouldn't expect it to change much, and we'll see what even the post-device measurements are. It's going to be pretty close.
Yeah, and you can see here, I think we're missing a lobe here posteriorly. You can see it on 135.
Let's see that angio again. Play that again, Billy.
Yeah.
No, just this last one.
The last one.
So I'm just going to give a good tug test here and see if it...
Yeah, I don't know.
I think, Rahul, if you see that 135...
Yeah, I see that. So if you tug and clock, right, you might be able to catch it.
Exactly,
right?
yeah.
But obviously, if you came back a little proximal, you're going to get it, but you might get it. That pec is holding you.
Yeah.
So what does the panel think? We should probably recapture maybe a partial and bring it back a tiny bit? Or what do you think?
Definitely recapture and bring back proximal.
Yep.
Yeah. So let's do that. I'm going to just partially recapture this here.
Hey, Rahul, here's a question for you. Are you seeing more utilization of true steer because you can't stick inferiorly with your concomitant procedures?
I have yet to use true steer on a concomitant. It really, again, it's a little bit of a biased population because, quite frankly, the majority of my cases are persistent, so more advanced disease, more left atrial enlargement. Do you really need it? It's really that, as you guys know, right? True steer is phenomenal for that anterior chicken wing, and especially when it's a low lateral anterior chicken wing. But other than that, sort of just, it's still normal anatomy as far as reaching it. And let's face it, because the development since Flex, and now obviously with Flex Pro, with the radial force being greater at the ostium or at the closure point, it sort of figures itself out, right? Even when the initial deployment's a little wonky.
Oh,
that's too proximal.
Yep.
Yeah.
I actually think your last deployment didn't look bad.
Yeah, I think that's why the pre-procedure TE, I think our depth in the anterior lobe wasn't that great. So I think that's test it, please.
So here's a question while you're repositioning. So let's say these patients in option are low bleeding risk patients, so they can take anticoagulation therapy. So let's say that you bring the patient back at repeat imaging and they have a 2 or 3 millimeter crescentic leak, not an uncovered lobe. What are you going to tell them? Are you going to keep them on anticoagulation therapy? You're going to stop the anticoagulation therapy? How's this going to play out? Because right now, most of our patients can't take anticoagulation therapy because it's kind of academic. But on these patients, it's actually not just academic.
That's a great question, and I think there's so much to untuck there. But it kind of does relate to the fact. So remember, this isn't the usual bit as far as post.
that looks better.
Post just a standalone appendage case, right? We're going to anticoagulate for 3 months anyway. So that's right off the bat, right? And plus, I'll tell you, there's more and more data where you might suggest that half-dose NOAC is actually the way to go on these patients. And so that's a factor. But I definitely think it matters for the patient anatomy and overall risk factor. And obviously, we've got pretty good data, big number data, that leaks are associated with DRT and stroke risk. And so as small as that number might be, 3 millimeters, when you say 3 millimeters, that's kind of like right on the border, right? If it was less than that, I would leave it alone and reimage in 6 months. If it was more than that, I would definitely plug or coil or both. And so the 3 is sort of the in-betweener.
Yeah, and I think it's also how we measure the leak, right? It's not just like 2D, it's a crescent shape. So I think there's a lot to learn in that space. But going back to the angio, you can see there's a big ridge in the middle, and that's preventing us from going deeper than this deployment. And this is how it looks right now. And maybe we can do the measurements. And,
we can get measurements, but I'd ask the panel, what do you guys think?
Just from an angiographic perspective, forget the TH for a second. It looks like a lower end of compression just by the shape of the device.
Yep.
My concern would be that now the ablation has been done, the contraction will be more aggressive. So will there be migration at 45 days?
I think I'd be concerned. I don't know that post-ablation it's going to be, again, he was a paroxysmal patient. Did we change anything in terms of contraction? I doubt it, right? But just in general, I think we're a little prox, yeah?
Yeah.
I think getting that deeper is going to be a little challenging because of the ridge in the middle. I think we have to go into one of the lobes and...
I think I would actually do that. And this time, as you're releasing the device, if you try to keep that counter as the device pops out, it should tuck. And I think you'll be okay.
Yeah, and then that's why I think on the 135, if you look, the ridge is right where and
100%.
That's why the pre-procedure imaging, the maximum depth was in that anterior lobe.
Yep.
And but if you're too deep, you're gonna miss that posterior lobe. And
you could actually then, if you get anterior like your initial deployment and then clocked as you're released, you probably get it.
Yeah, that's what we did the second time.
Yeah. Anyway, while Alok is recapturing and doing that, why don't we, in the interest of time, let's go to my slides.
Okay.
And then we'll come back as soon as we get this. So I wanted to actually go over the data, why we're so interested in concomitant. Now, I'll tell you, I've been doing concomitant for over a decade, and but mostly for the advanced patients, persistent, long-standing. But we've had a ton of data that you can do this safely and with a good degree of efficacy. But obviously, Option was the first randomized clinical trial to basically put this to bed, and of course has led to the CMS code and approval to allow us to do this in the United States, where it was being done in Europe and certainly in Australia for ages. But so this was a large trial, 1,600 patients were randomized 1-to-1, essentially 800 patients in each group. Click forward. And then you can see they were split up in whether there was the sequential cohort, which was, where the ablation was done first, and then subsequently they had their appendage closure. And then next, click forward. The concomitant cohort, which was sizable, you can see in the device arm, 328 patients ended up having a concomitant procedure where the appendage occlusion occurred within 30 days of the ablation. Go ahead, next slide. Or just go ahead and click through. You can click through some more and keep going. Keep going. Okay, perfect. So this is, you can see the baseline characteristics, a pretty typical population for any catheter ablation or appendage trial. I see the average age at 70. You can see the CHADS VEST score on average was 3.5. Next slide. And just go forward. It's just outlining. So here you see, and this was the idea here, is that so as far as ablation timing, regardless of what you did, concomitant or sequential did not impact the treatment effect. And that's important, right, in terms of trying to figure out which way to go is better. Look, how are we doing here?
Yeah, so I think this is the last deployment. And you
perfect.
can see on the angio that it's, can you play that angio, please? And you can see on the TEE 135 and 45-degree views that this looks much better deployment. And And we went deeper into that and then just hold that forward tension and then clocked it a little bit to prevent it from
that's beautiful.
migrating back. So that's where we are. We'll do some measurements. But to your point, Rahul, I think this trial, again, it's a
You
great
can go back to my
trial.
slides.
But I think it's, people are going to say it's a non-inferiority trial. A lot of, the endpoints, were not sensitive enough, so it biases towards the non-inferiority.
So-
But I think and also the procedure-related bleeding wasn't looked into the superiority.
So let's go ahead and click through the slides. I want to show you something. So this is the efficacy and safety data, obviously with the concomitant or essentially using appendage closure versus OAC. And as you can see, from an efficacy standpoint, the same. And that's exactly as you speak. And I think we heard from the lecture preceding this course. I mean, all these trials in the panel discussion are non-inferior trials. Right? And it's not to downplay, but statistically that's an issue. But look at the safety endpoint. And of course, this was driven by bleeding. And there was a significant difference between using the device versus oral anticoagulation from a bleeding standpoint, just as you'd expect, right? So next slide. So if you look at this, there was no increase in the procedural events. Are you adding risk in doing both procedures together in the trial? That was not the case. Next slide. And as far as 3-year outcomes in terms of real clinical outcomes, including all-cause mortality, no difference. Next slide. And you can go ahead and go further. And obviously, we implanted Flex Pro, which I just throw this up there because the interesting business with the difference in the coating of the surface of the device, and will that matter as far as your anticoagulation regimen post-procedure? So getting to the sort of questions that Alok is, of course, raising, which is, I think, are the most important part of this discussion. That's perfect. Let's say right there. So here's my question to the panel as the electrophysiologist, right? Should all patients be evaluated by EPs for rhythm control? Because so many times myself, in terms of patients I see, they're referred for appendage occlusion. Many of them need rhythm control. It's a sizable percentage, and vice versa. Patients referred for AF ablation often are really good candidates for left atrial appendage occlusion. That second question is, should all patients get either, or if they should get either procedure, should they get both? And does this push the procedure? And of course, here's where I'll be controversial to the panel. Does this push the procedure to the electrophysiologist? So we can, before the last slide, yep. I open up to the panel and your opinions on this.
Yeah.
I'll take the third one because I think it's actually a really interesting question. So in my practice, we have 5 operators that do Watchman that are evenly split, not perfectly evenly split with 5 between interventional cardiology and electrophysiology. But I have 9 electrophysiologists that are now going to learn this procedure. Figuring out the logistics of that is a totally different story. But eventually they'll all do it. But there is so much business to do that I don't actually think it matters. Our electrophysiologists can't even get their AFib ablation cases scheduled, never mind adding on Watchman cases to that. And then when Champion, let's face it, Option was a preliminary look at Champion, right? Kind of the same patient population. So Champion will probably be positive, and when it's positive, there'll be more business than anybody can possibly do. That's my take.
Can I ask you a question, Rahul, and maybe pertinent to your second question there of should all patients who get either procedure or get both? There is a lot of excitement with our EP colleagues about concomitant procedures, but there's a little hesitation also because every time that I want to send someone, especially with permanent AFib, they said, should we close because they feel that they can lose the access to whatever you guys do underneath the ridge, and say don't do it yet because that may impact future ablations and potentially conversions to normal sinus rhythm. So is this for all? Is this something, or is this even device specific, right? Because I've heard, it's Watchman probably that blocks the access underneath the ridge, but maybe other devices coming down the line, like laminar, for example, can kill the tissue within the ridge and be done.
I think that's a lot of important points there, right? There's no doubt that a lot of this depends on the patient population and, of course, what you end up doing. Right, so this is one extreme, right? This is a healthy patient, paroxysmal atrial fibrillation, using PFA, so we're really not altering the anatomy very much at all. And so we're doing a quick left atrial appendage occlusion at the same time. Compare and contrast with the persistent long-standing patient who is not, let's say, for whatever reason, they're not a candidate for a converged procedure, and they're getting an extensive catheter ablation. They're getting an anterior line and maybe appendage electrical isolation. Those patients need to be plugged if the appendage is isolated, but the reconnection rate electrically is really high. So that gets to the different type of devices out there, right? In terms of, okay, on one hand, if you have an endocardial or essentially within the appendage occlusion device, and you have edema and swelling around the ostium or at the ridge, there's your increased leak rate. Okay, well, you could take a different device, let's say Amulet, where you have a disc over it, where your closure rate's more complete, but now you need to anticoagulate 3 months post-procedure, and we're all aware of the data with higher effusion rates associated with anticoagulation with Amulet. So now you're trading off anticoagulation strategies versus type of device. And then to your point with laminar, maybe append, and certainly going back to Lariat, where you're actually killing the appendage. And is that a useful thing? And I would say, in my opinion, based on the BELIEVE trial and the meta-analysis, that in persistent long-standing AF, the appendage is absolutely important. And our surgeons have proved this for years, right? And why actually I think the convergent procedures are a very good procedure. And left atrial appendage clipping is going to be something we're going to see more and more. Now we're on LAOS 3, right? So I think stay tuned. I think we're still learning about this. But I think a lot of it it's so variable. I think as to what your question sort of outlines.
Yeah, and one other thing is, I think the more I'm doing it with EP colleagues, there's pre-procedure planning is still important, and I think not all appendages need that mid stick. I think, and sometimes you need to go very inferior and sometimes very posterior, which might not be possible with concomitant cases as of yet. I mean, it might change with the sheath is more steerable. And with the true steer, it might be different. So I think that might also play a role in this approach.
Maybe I will add something. I think, Mike, your question is very important. I think the patient we see in structural heart work or the burnout AFib, where there's no chance in the world, like 88 years old with severe AS and severe MR. So we do the TAVR, we do the mitral clip, and then they bleed, we do the Watchman. So there's no rhythm concern. But I believe that what you're doing is more preemptive or preventive Watchman on a AFib, which could be cardioverted, could be ablated. That should go to you, and I will be more than happy to send it to you. But the other one, more complex, the one we do is the one where you have a clot in the appendage. We need to suck the clot out, put a Watchman. We have Sentinel, the more complex one with no AFib ablation potential. I think this is the patient that we do. The one reason I'm so excited about this trial is I think there's a lot of patients that we could do the mitral clip, for example, or the Pascal, and then we do concomitant Watchman. I think that for me is the low-hanging fruit. So the concomitant Watchman with other procedure, I think it's a great step forward, I believe. Yeah.
Yes, Srinivas, you got a comment?
Yeah, so I think being more of almost like I'm aging myself. I'm sitting next to Mike right now. I think when the surgeons just say, don't stand to, we should be bypassing. As an interventionalist who does Watchman, I do feel it's really comes down to the learning curve issues with new operators in the EP field doing it, because the reason is the expectation of patient population right now with the newer device is so high. I don't know where that curve is, where new operators who are doing ablations, adding Watchman to it and having complications is acceptable. So it is something that I think is a real thing, because the level of success with this device is so high. And as someone who does help out others with DRTs, taking thrombectomies, with putting coils and plugs in, I'm not sure how many EPs are doing that. So that is something that I live in.
I think the take-home message
it's variable. It's variable center to center. I mean, for example, here at HonorHealth, the vast majority of appendage devices are being done by the EPs, and the only folks that are doing multiple types of devices are the EPs, and actually the ones that are doing the plugs and coils are the EPs. So it's very different, right? So it just depends center to center, right? I would never. So Seibel and I were in fellowship together. And I would never tell Seibel as an interventionalist that he shouldn't be doing appendage occlusion. He's had more experience than anybody in the world, right? And similarly, I think it just, as you were stating, A, it depends on who's doing it, who has the best experience. B, the trials suggest that you can do them both, together, and actually it's more than just option, right? We've had data for more than 10 years, going back to Karen Phillips doing concomitant procedures in Australia. And then on top of all that, there's, to the earlier point, there is so much business, there's so much AF, that isn't really an issue thinking about who's going to be doing it. It's like whoever can and do it well and do it safe.
I think it's just a take-home message here is that it's important that we learn what you do and what the indications for ablation are. Just like when I see a patient with MitraClip, I need to pay attention to, do they need CRT? There's a lot of room for collaboration. We're all part of integrated groups. It's really important that we learn what each other do.
Yeah.
Well,
and one last question I have before we close is, in the option trial, there were still 22 events, if I am correct, in the procedure-related events, and so it's a 2.8% risk of procedure-related events, and it's not zero, or so 2.8% is still, I think, a lot of events in this group. So I think we have to be, and if that events were counted, the superiority, it wasn't superior from the procedure-related adverse event, so it was not inferior. So I think we still have to be mindful of that there is still procedure-related issues.
I think that's absolutely right. Okay.
all right. Well, Rahul and Alok, that was a fabulous demonstration, and we are all going to applaud great outcomes, both electrical and mechanical there, plumbing, and we really appreciate all your great work. So thank you so much. We're actually